Hi guys, good evening to everyone and welcome to the clinical case discussion. As you know, your exams are approaching. I'm getting a lot of messages about how to improve your skills as well as the speed of doing these clinical scenarios. So not only we will discuss particular cases, but we are also going to discuss certain tricks and tips how to increase the speed of doing these questions, because in the paper it takes a lot of time to read these questions, comprehend these questions, then go about the options and come to the final answer. So if you are doing the question right but you are taking more time than your neighbor, then you can be in trouble. So it's not about solving right. You don't have any choice. You have to solve it correctly, but also you have to solve it in the minimal possible time. So how to do that, we will be discussing that also. I hope my audio video is fine. Please, somebody can comment in the live chat if my audio video is clear. And I hope you people are there with me so we can have a live discussion. Every time we will be discussing anything, you can answer me in the chat box so that you have that live interaction and you can come to know what are the things you were thinking in the correct manner and what are the things that you were not thinking in that so correct manner, right? So somebody can please comment if my audio video is fine. Good evening everyone. INI-CET paper 8 May, NEET 21st. So I think it's the right time to ace your preparation with the clinical case scenarios. You already know now the number of one-liners have drastically decreased, and you know that the speed really matters in solving these clinical scenarios. Yeah, hi Avinash. Okay, thank you. Audio video is clear. All right. Thank you so much, guys. Thank you. Har Simran. So my children are there. Okay. So, because you are the guys, you are there. So we will be having an amazing discussion of these clinical scenarios, and as promised. Okay, then some people have started giving the answers also. Right. Awesome audience, I think. So I am not only here to give you the answer, I will also tell you the approach, how to go about it, and certain tricks and tips, because these are the things that will help in decreasing your duration, how to do these questions. So let's get started. I'll start with this question. We have a 5-year-old boy. This 5-year-old boy is brought to the emergency department with the blurred vision, right eye pain is there, headache is there, and look at the past medical history. We have otitis media, dental caries, eczema and allergic rhinitis. Now you have the history of otitis media, that is very common in children. You have history of dental caries, again eczema and allergic rhinitis. So basically we have a history of allergy, right? We have allergic rhinitis also and we have eczema also. Then he is also allergic to insect venom. Now every person may be having problems if the insect venom is there, but this person is also allergic to insect venom, right? Temperature is more, see it is 39.4, pressure is 100/70, it's low. Pulse is 120 per minute, respiration 20 per minute. Examination shows, now that I'll do it with a different color. Examination may you have conjunctival injection, pain with extraocular movements, periorbital edema, limited adduction and proptosis of the right eye, while left eye is normal. So one thing which is very, very evident in this question is that this is your unilateral. This is unilateral proptosis, and that too in a child. See, this is a case of unilateral proptosis plus it's a acute proptosis, and that too in a child. Which of the following is the most common predisposing factor for this child's condition? Now the injury to the insult is that they are not asking you the diagnosis that you have to make, because what they are asking is the commonest predisposing factor for this child's condition. So already you should know what is the child's condition, only then you can tell the predisposing factor. Now, before reaching to the final diagnosis, can you tell me what is the cause of unilateral proptosis in a child? What is the most common cause? Yes. So, yes, Avinash, Harsimran, Chandrasekhar, can you tell me? I don't want the answer, guys. ठीक है, अभी मुझे आंसर नहीं चाहिए. What I want is, what is the most common cause of unilateral proptosis in a child? Because what is my approach? You have to do so many things. You have to learn so many things before reaching the final answer. So we are not going to do just one question in this question. We are going to learn series of things with the help of this one question. So my first question is, what is the most common cause of, what is the most common cause of unilateral proptosis in a child? And people are giving me the right answer. If I talk about Avinash, no, I am talking about unilateral proptosis. See, proptosis in child. If I am talking of the proptosis in a child, right, I have two options. It can be unilateral or it can be bilateral. It can be unilateral proptosis or it can be a bilateral proptosis. Now, the most common cause of unilateral proptosis is what it is? It is orbital cellulitis. So many right answers I can see flashing up. Orbital cellulitis, very, very correct. While what is the most common cause of bilateral proptosis in the children? This is metastasis. This is actually metastasis, and this metastasis means secondaries. So they may be coming from, number one, AML. They may be coming from AML. AML is chloroma. You can have chloroma, right? There was a question this year in NEET 2021 that was ophtha and patho integrated question where they asked about chloroma. And number two is your neuroblastoma. Number two is neuroblastoma. So you learn two important things. What is the most common cause of unilateral proptosis in children and the most common cause of the bilateral proptosis. Yes. So this is the first thing that you have learned. Now, because this is unilateral proptosis and it is acute, so we can take it as a case of orbital cellulitis. Now, let's match the clinical features. Orbital cellulitis. What is cellulitis? Cellulitis is an acute inflammatory condition. It's an infectious condition. It's an inflammatory condition. And this orbital cellulitis, what is the most important predisposing factor? The infection is coming from the neighboring places. Now, what is the most common neighboring place from where it can come? That is your sinus. Therefore, the answer is bacterial sinusitis. Now, other important question is, why it is so much common that the infection from the paranasal sinuses are coming to the orbital septum, and from the orbital septum also they can further go to the cavernous sinus, and that is why in the risk factors of the cavernous sinus thrombosis you have orbital cellulitis. Yes or no? So it starts from the sinusitis, it can go to cellulitis. From cellulitis, it can go to cavernous sinus thrombosis. And if the patient is having comorbidity, now I have so many things in my mind. Now, because this is a child, you are thinking in the lines of orbital cellulitis. But if it would have been an adult, then I would have thought of the cavernous sinus thrombosis also. I could have also thought if it is a comorbidity, a diabetic patient maybe, or maybe an immunocompromised patient, a COVID patient, Then we can also think about the orbital mucor mycosis. Orbital mucor mycosis is also a rhinocerebroorbital disease. So just the age of the patient will make so much differences in the perspective and the approach towards the question. If I give the same question with the change age of the patient, along with, I say there is a comorbidity, maybe neutropenia, maybe a iron overload, immunocompromised patient, steroid therapy, hemochromatosis, anything like this, then the same patient can go on the lines of orbital mucor mycosis, having the rhinocerebroorbital disease. Is this clear, guys? Are you getting this? Yes. So which sinus is more common? Don't worry, I will, Sageet, for that you have a session tomorrow. We are going to discuss the previous year questions of the NEET and INICT in tomorrow's session. So again, I'll be live tomorrow. Do watch that session also. Yes. So the next question is, which sinus? Now, I have already told that it is actually the bacterial sinusitis. The next question is, which sinus is most commonly causing the infection? So which sinus? Is it a frontal sinus? Is it a maxillary sinus? Is it a ethmoid sinus? Sphenoidal sinus? Which sinus is most commonly causing this? Second, so please answer that. Then I was saying that why actually it is very, very common from sinuses. You have to answer me. You have to give me the name of the sinus. And the second question is that why it is most common from the sinuses? Because that place is actually valveless. So because of the valveless system. This is again very, very important. Valveless venous system. Because of the valveless venous system, we don't have veins, valves in the veins. That is why this is so much frequently getting infected from the sinuses. You can see the different veins here. If you look at this one, this is your lacrimal vein. Then if you look at this one, this is superior ophthalmic vein, and this is your cavernous sinus. This is the cavernous sinus, right? Then we have got this. These are the ethmoidal veins. This is your anterior ethmoidal. This one is your posterior ethmoidal, right? And if you see, this is superior ophthalmic vein, so this will be inferior ophthalmic vein. So we do not have valves here. That is why this is valveless system, and that is why it's very common, right? Now, since we have taken the case of orbital cellulitis, let's discuss about it. See this. Now, what are the things you should know? Now, when I am talking about the orbital septum, right? So, when the infection is just anterior, it is just anterior to the septum, then that will be called as the preseptal. Then this is called as the preseptal orbital cellulitis. But when it is posterior to it, then it is called as the postseptal, right? So, I have got two kinds. One is your preseptal cellulitis and another is orbital cellulitis. Now, until and unless it is crossing the septum, it is not coming to the ophthalmologist. So, basically, a funny thing is that the preseptal cellulitis is actually treated by the pediatrics, while the orbital cellulitis is obviously treated by the ophthalmologist. So, I think this is one aspect that we never thought, that this is actually integration of ophthalmology with the pediatrics. Until and unless it is crossing the septum, it is not coming to us, and that is being treated by the pediatricians itself. Now, though the complaints which are given by the child are similar but less severe. So these children will be coming with the redness, they are coming with the edema, conjunctival injection is there, but yes, the degree of the problem, if you look at the eye, is much less severe in comparison to the frank orbital cellulitis. But the thing is that these patients are actually not having the visual acuity affected, because their visual acuity is not affected. Now this is a very important point, because the same complaints, visual acuity not affected, your answer will be preseptal cellulitis. If the same complaints, you say that the visual acuity is also affected, you have proptosis, you have ophthalmoplegias, you have pain on ocular movements, then it becomes orbital cellulitis. And once it is a case of orbital cellulitis, you will have to look at the other things also. You will have to do the monitoring also. Why? Because if it is a case of orbital cellulitis, then you have the risk of cavernous sinus thrombosis. So certainly you cannot take it easily. If it is a case of orbital cellulitis, you have to do something to rule out the cavernous sinus thrombosis, and the diagnosis is clinical. So here we do not require any, investigations, X-ray imaging, etc. Just the pediatricians are giving amoxiclav and it is being treated. Right? So that is actually a pediatrics diagnosis. Now if you come, yes. So yes, everybody of you have given the right answer. It is actually the ethmoidal sinus. It is the ethmoidal sinus that is most commonly involved. So I think I have given you the answer also in the pic form. See, this is your ethmoidal sinus and this is your question number 2 which can be asked. Avinash, here also we are having the pain on ocular movements. It is not directly the optic neuritis, but yes, optic disc congestion is there due to the back pressure changes. That is why we have pain on ocular movements. So we have fever, we have pain on ocular movements, and we also have the involvement of the extraocular muscles. Why do we have involvement of extraocular muscles, guys? Yes, so if you see, this is your orbit and this is the eyeball, right? Now we have something at the apex of the orbit, common tendinous ring called as annulus of Zinn. And from this annulus of Zinn, we have different muscles which are taking the origin. So what is happening? If I have a problem with the orbital septum, these extraocular muscles are involved. These can be like, superior rectus, inferior rectus, medial rectus, lateral rectus. All these muscles are involved, and that is why we have pain on ocular movements. Then we have got the ptosis. Why I am having ptosis? Because we have involvement of the LPS muscle also. Now another important question is, how will you confirm it? So another important question is that we can confirm it with the help of the CT scan. So these are the related questions. First of all, was your diagnosis was orbital cellulitis? What is the difference between the preseptal cellulitis and the orbital cellulitis or the postseptal cellulitis? How will you confirm the diagnosis? Then what is the most important predisposing factor? That is your sinusitis. Which sinusitis? Ethmoidal sinusitis. Okay? Now, once you are having all this, how can you treat this condition? Treatment actually depends upon the severity. So mostly we are giving the IV treatment, right? It can be cefotaxime or we can do the IV vancomycin also. Now another important thing is most common pathogen. Can you name the most common pathogen also, guys? What is the most common pathogen that is actually involved? What is the most common pathogen which is involved in the cases of orbital cellulitis? Please answer this question. Then we will discuss the classification and staging also. Postseptal. Reddy, I do not know what question you have answered in the form of postseptal. Please let me know that. Now there is a flow chart, because in the clinical scenarios you have lot of questions related to the flow charts also. So I have tried to prepare this flow chart. this flow chart with the help of which we can actually answer so many questions. Suppose you are having any patient who is coming with pain, who is coming with the tenderness in this orbital or the periorbital area. Now, whenever you have question related to the pain, tenderness, swelling, or we have redness in this orbital or the periorbital region, you have to see what is the general condition of this child. So first thing is the general condition. Look at the general condition of this child. If the general condition is good, then it's okay. If the general condition is the unwell, child is very sick, then the first thing is you have to treat this patient as a case of sepsis. And sepsis is an entirely different thing. Okay? Now number 2, if it is no, see I am highlighting this no here and yes with the green color. Okay? So if it is no, then what are the other things you have to look for? If it is no, then look for the signs of the proptosis. Look for the visual acuity. Visual acuity ki significance bhi I will tell you, because whenever we have this proptosis and edema in the periorbital region, I can have orbital cellulitis, I can have cavernous sinus thrombosis, I can have superior orbital fissure syndrome, I can have orbital epic syndrome, I can have the caratico-cavernous fistula also. So I will tell you how to differentiate these things. And that is why it is important to see whether you have proptosis, whether or not you have decreased visual acuity, you have optic discongestion, we have conjunctival chemosis that is there, pain on ocular movements is there or not. And if it is yes, now see here, if it is yes, then you have to treat it as a case of orbital cellulitis, and that was the case in this question also. So you can directly treat this question as a case of orbital cellulitis from this flowchart also. But if it is no, then what are the things you have to see? You have to see any of the criteria. Number 1, if it is less than 3 months of age, significant swelling or unable to perform the adequate eye examination, or you have the Hib immunization which is not there. These are actually very severe characteristics. So if you are having this as yes, then you have to treat it as a case of severe periorbital cellulitis. Severe, then you have moderate, and then you have a mild. So what are the things? If you have severe swelling, if you have inadequate immunization, then it is severe. While if you have moderate swelling, then it is moderate cellulitis. If you have minimal swelling, then it is minimal cellulitis. Okay? So how to make the diagnosis of cellulitis, how to differentiate between preseptal and septal cellulitis, how to differentiate between mild, moderate and severe, that also done. Okay? Now coming to the next thing. Next thing is the Chandler's classification. Now the first important question is, what is the classification that is followed in orbital cellulitis? This is again an important question which can again be asked. So sometimes even the name of that classification is important. They are not going to ask you a thing which is beyond that. So first thing is the name of this classification. Is it visible now? Flow chart is not visible. Okay, so let me show you the flow chart again. But I had not written anything on the flow chart, Pankaj. Flow chart अपने आप ही लिखा हुआ है, मैंने कुछ नहीं लिखा है. See this. You can see the flow chart again, Pankaj. First, we have got the pain, tenderness, swelling and redness of the orbital region. Then you have to see, मैंने बस इतना ही लिखा था, look at the general condition of the patient. If the general condition is not well, then you have to treat the patient as a case of sepsis. If the general condition is well, then you have to go to see the features like you have proptosis, you have decreased visual acuity, restriction of the ocular movements, ophthalmoplegias, chemosis. That means it is a case of orbital cellulitis. Now, once you treat it as a case of orbital cellulitis, we can say whether it is a severe cellulitis, moderate or mild. दैट आई हैव शोन यू. ठीक है, अभी चलते हैं दूसरी चीज में. दिस इज योर नाउ ओके है पंकज? ठीक है, so it's good. Please let me know if there is any problem, then I can correct it. ठीक है, so we have the Chandler's classification. This Chandler's classification is used for the orbital cellulitis. So how to remember it, है ना? So for this we have a mnemonic for you. See this? This is a mnemonic, POSIC. POSIC. So what is P? P for preseptal. This is preseptal cellulitis. So obviously it will start from preseptal, then it will go to orbital cellulitis, and last में it can go to cavernous sinus thrombosis. ठीक है ना? तो it is starting from preseptal, then O for orbital cellulitis, then it can form the abscess. Then we have got S. S for subperiosteal abscess. फिर I है. I is intra. It is intraorbital abscess. So this is your I. And last C is cavernous sinus thrombosis. So C for the Chandler's classification. So you can learn it as C POSIC. C for Chandler's classification, P for preseptal cellulitis, O for orbital cellulitis, S for subperiosteal abscess, I for intraorbital abscess, and C for cavernous sinus thrombosis. So C से ही start होगा, C पर ही end होगा, C POSIC. ठीक है, उससे हम याद कर सकते हैं. Then you are also solving the questions of proptosis. What is the most common cause of unilateral proptosis in children? What is the most common cause of bilateral proptosis in children? Right? ये भी हो गया. उसके बाद एक और important चीज, what are the risk factors for the cellulitis? Because most of the clinical scenarios will demand that you should know the risk factors. So again, I have one more mnemonic for you, the risk factors. And please, I would advise you to make a separate notebook for your DDs, because very very frequently I am going to give you now the mnemonics and tips and tricks, so that you can remember, you can revise these things at the last minute. So this is going to be your 20th notebook. Whatever you are going to add from your GTs, from your SWTs, or whatever are your volatiles, you can add these things also. So this will help you in remembering the things very very easily at the last minute, है ना? Recall is always a problem. So how will you recall? तो risk factors के लिए you have a mnemonic, that is site. Thick pen I am going to use, पंकज ने बोला है. ठीक है, so we are going to use a mnemonic, that is a site. So S for sinusitis. See, अगर हमें ये पता होगा तो this first one is going to help you in this particular clinical scenario, है ना? This first one is going to help me in this clinical scenario is the sinusitis. अभी दूसरा देखो, I for insect bite. This is also available in the question. We have sinusitis, we have insect venom, allergic to the insect venom. Then G. G is actually your glandular spread. Gland से spread हो सकता है. So instead of the insect bite, they could have given you the example of glandular spread. H for hematogenous spread. Blood spread भी हो सकता है, sepsis हो सकता है. And T for trauma. तो trauma is a funny thing because you know trauma is not related to anything and trauma can cause anything. वो मैं जब cataract पढ़ाती हूँ तब भी बोलती हूँ कि most common cause of cataract is actually senile cataract, but after the senile cataract, any other cataract which is common is trauma. Any age, unilateral, bilateral, anything can occur, है ना? तो trauma जहाँ पर भी जो हमारे seniors थे ना, वो भी हमको ये सिखाते थे कि जहाँ पर भी आपको risk factor याद ना आ रहा हो, और फर्स्ट वाला ऑफ कोर्स आप बता चुके हो, है ना? उसमें तो रिस्क ज़्यादा हो जाता है, बट विद द नेक्स्ट वन यू कैन गो विद द ट्रॉमा, क्योंकि ट्रॉमा इज़ वेरी कॉमन इन द डेवलपिंग कंट्रीज लाइक आर्स. तो रेज इंट्राक्रेनियल प्रेशर होता है, ऑप्टिक न्यूरोपैथीज होती हैं, कैटरैक्ट्स होते हैं, एवरीवेयर यू कैन ऐड टू टीज. टू टीज क्या होता है? वन इज एक्चुअली टी फॉर ट्रॉमा एंड अनदर टी इज ट्यूबरकुलर मेनिंजाइटिस TBM. ये सारी चीज़ें क्या होती हैं? These tricks and tips books cannot teach you. This can be taught actually only by the experience, and even consultants will not tell you these things. I think these things are best told by your seniors, because they learn it over a period of time by observing the things, facing so many vivas. So you get to know. But here I am telling you because I want that you know these things, and it is actually easy for you. So in every risk factor you can go with the trauma. बस glaucoma में मत लिख के आना, glaucoma में trauma नहीं होगा. But even trauma can cause glaucoma, but it will not be a genuine risk factor. हो सकता है हाइफिमा से ट्रॉमा से यूवियाइटिस होके भी ग्लोकोमा हो सकता है, लेकिन क्या होता है ना कि डोंट फॉलो इट ब्लाइंडली, लेकिन मोस्ट ऑफ द टाइम से वर्क करता है. ठीक है, ओके. हाँ, उस पर भी हम अभी आने वाले हैं. रेडी, वी आर कमिंग टू दैट व्हाट इज एक्चुअली द रोल ऑफ एक्सरे इन ऑर्बिटल सेलुलाइटिस. टुडे वी हैव टेकन दिस केस. तो आगे बात करते हैं. नाउ इफ आई एम टॉकिंग ऑफ इमेजिंग, ठीक है ना. So if I am talking of imaging, what is a role? So basically my role is when I am doing the imaging, I can go for X-ray and then we also go for the CT scan. ठीक है. So X-ray basically we are doing to differentiate between the pre-septal and the septal cellulitis. So whether it is before the septum or it is after the septum, for that, plus you also have to see the involvement of the sinus. You also have to see the involvement of sinus. That is why we are doing X-ray. Now can you tell me why we are doing the CT scan then? X-ray say we are getting differentiation and we are seeing the sinus involvement also. Then why I am interested in doing the CT scan? क्या already means we are more worried about orbital cellulitis, or actually we are worried about something else? I will show you the picture also of a child having the orbital cellulitis. This is the picture that you see in your eGurukul notes also, the same picture. See this one. So child is coming with this type of eye, and it is unilateral proptosis hai, and parents are worried actually because of the red eye, but actually we as ophthalmologists are not worried about that red eye. We actually get hospitalization of the patient urgently. We start with the monitoring. We do the 4-hourly vital monitoring, and we do post the patient for urgent X-ray and CT scan. So why actually we are worried about this? Why we want to get this X-ray and CT scan done? Can you tell me that? Anything? We are doing the 4-hourly vitals also, temperature also. Now, first important thing is X-ray will help you in knowing the sinus involvement. Another important thing is that we do not have the lymphatic system in the eye, and we have the valvular system. So a thing which is actually golden rule is necrosis is the rule, and that is the reason why in cases of the orbital mucor mycosis also we get the angioinvasion, we get the black star formation. Black star formation, you should be able to differentiate this from the black star also. I will show you that also. Just wait. Yes. See, star ही खुला है. This is actually the black star formation, which is actually the result of angioinvasive disease, which is orbital mucor mycosis. So you should be able to identify this lesion and differentiate it also. Okay. So basically, why I want to do the CT scan? I want to do the CT scan because actually I am interested in looking at the optic nerve, if the optic nerve is involved or not, if the cavernous sinus is involved or not. That is the reason I am interested in doing the CT scan, because one important Yes. What does it mean to rule out necrosis? Necrosis, ready? What is necrosis? Necrosis means the dead tissue. Debridement has to be done for the necrosis. So in order to find out whether or not the blood vessels have been affected, so that is actually the cause of necrosis. You have to find out that. That is the reason why we are doing these investigations. Now basically we are worried about the cavernous sinus, cavernous sinus thrombosis. Okay, so basically we are worried that this child may go into the cavernous sinus thrombosis. And if you look at the risk factors, what are the risk factors of this cavernous sinus thrombosis? One is your orbital cellulitis itself. So if a child is having the orbital cellulitis, then this child may go into cavernous sinus thrombosis. Number 2, we can have the acute ethmoidal sinusitis. That child can also go into the cavernous sinus thrombosis. And number 3, we can have the infection in the dangerous area of the face. Now another question for you guys, what is the dangerous area of the face? I hope this is visible now. These are the risk factors of the cavernous sinus thrombosis. Can you tell me the dangerous area of the face? So we are going to solve so many questions. Yes, very good Avinash. Bone erosion is very important. You have to see the optic canal involvement because optic nerve will pass through the optic canal. What is the other structure that is passing through the optic canal? Guys, this is your one question. And second question, what is the dangerous area of the face? This is your question number 1. And what are the structures passing through the optic canal? This is your question number 2. Can you answer? Very good, ready? Below the nose and above the upper lip. Yes, Harsimran. So it is the triangular area exactly at the tip of the nose and this septum as well as this area of the upper lip. This is your dangerous area of the face. Very correct. This is the dangerous area of the face. So if you are having the infection in this dangerous area, it can go into cavernous sinus, acute ethmoidal sinusitis and orbital cellulitis. What are the structures which are passing through the optic canal? Very good, Harsimran. Awesome. So it is actually optic nerve and ophthalmic artery. Ready? ये क्या है? 2 plus 3 plus 4. I do not got this. What is this? 2 plus 3 plus 4. Okay. So we have optic nerve and ophthalmic artery. Very good. Preetham, very good. All right. Okay. Now what are the clinical features? Clinical features of the cavernous sinus thrombosis. Now, if you want to discuss what are the features of cavernous sinus thrombosis, you should know what are the structures passing through the cavernous sinus, because many a times we have this confusion whether it is cellulitis or it's a cavernous sinus thrombosis or it's a fistula or it's a superior orbital fissure syndrome or it's a orbital apex syndrome. Okay? So what are the structures passing through this cavernous sinus? We have got 2 parts. एक तो हो गया center of the cavernous sinus and second is your lateral wall. We have the center of the cavernous sinus and then we have a lateral wall. Come on, now who will tell me what are the structures passing through the center of the cavernous sinus and what are the structures passing through the lateral wall? Fastest finger first. सबसे पहले कौन आंसर करेगा? Come on. Center से. First of all, tell me what are the structures which are passing through the center. Harsimran, very good. I am proud of you. So this is your internal carotid artery plus your 6th nerve. ठीक है, ये हो गया. Anushka, very correct. Very correct, Anushka. Lateral wall से ready. Please see your answer. Sixth lateral wall से it will not go, है ना? So center say it is internal carotid artery plus the sixth nerve. Lateral wall. So now these are the small things we actually get a mistake, and that is why we'll end up in what you call as a silly mistake. The basics should always be correct. ठीक है ना. सेंटर से हो गया इंटरनल कैरोटिड आर्टरी प्लस द सिक्स नर्व. लेटरल वॉल से यू हैव थर्ड नर्व, फोर्थ नर्व एंड फिफ्थ नर्व का फर्स्ट एंड सेकेंड डिविजन. सेंटर शी. ओके गुड. सो ये हो गए लेटरल वॉल से. नाउ ऑल दीज नर्व्स कैन बी इन्वॉल्व, बट व्हाट इज द फर्स्ट वन टू गेट इन्वॉल्व? The first one to get involved is the sixth nerve. That is why lateral rectus will be involved. So these people will come with the diplopia. Diplopia in the lateral gaze. So we will have the diplopia in the lateral gaze. Sixth nerve is involved. So lateral rectus is involved. Lateral rectus say diplopia in the lateral gaze. This is the first thing. It is actually unilateral to start with, and then it can go to, in 50% of the people it can even become bilateral. It is unilateral to start with, and in 50% of the cases it can become bilateral. So what are the other things that you were going to have? We can have fever with the chills and rigors, right? Plus we will have the ophthalmoplegias are there. You have the back pressure changes. Optic disc congestion can be there, right? We can have the conjunctival congestion, that is also there. We have the diplopia in the lateral gaze, that is also there. So what is the pathonomic feature? I hope this is visible, guys. So what is the pathonomic feature? The pathonomic feature is actually the mastoiditis. Why mastoiditis? Anybody can tell me the reason why we are having the mastoiditis as the pathonomic feature of cavernous sinus thrombosis? Anybody? Yes, very good. Third, fourth, ophthalmic division of the fifth nerve also, right? Okay, then anybody who can tell me why we are having this mastoiditis? Because you know, cavernous sinus is the largest sinus. It's a paired sinus. And what we have actually is the very good. We have the back pressure changes in the emissary vein. And which veins? Actually, the mastoid emissary veins. We have the back pressure changes in the mastoid emissary veins. That is why we have the mastoiditis as the most important pathonomic feature in cases of cavernous sinus thrombosis. ठीक है? Now, sometimes we are getting confused how to differentiate whether it is cavernous sinus thrombosis or it is keratico-cavernous fistula. ठीक है? Now, you already know the risk factors of cavernous sinus thrombosis. Now, if I talk about this is actually a keratico-cavernous fistula. Fistula means what? Which is an abnormal passage. So, this is actually abnormal passage which is between the internal carotid artery and the cavernous sinus. Internal carotid artery and the cavernous sinus. It can be any of its branches or it is the internal carotid artery itself. Now, when I have a communication between an artery and a vein, what will happen? The blood will always flow from a high pressure area to a low pressure area. So now high pressure blood is coming to the cavernous sinus. That is why again I will have back pressure changes, and due to this back pressure changes we will have again conjunctival congestion, we have optic disc congestion, we have ophthalmoplegias. So here you are, because you know why we have this fistula, usually you have history of trauma. Here usually you will be having the history of trauma, like in cases of cavernous sinus thrombosis or in cases of cellulitis, they will give you a history of infection, dental caries, insect venom, sinusitis. But in cases of the fistula, they will give you a history of trauma. Plus another important thing is, when you want to make a diagnosis, here you should have a typical triad. This is your bandage triad, a typical bandage triad. What is this triad? If you have this triad, it becomes very easy for you to make this diagnosis. This is PCB. PCB है ना, जब MBBS करने के लिए आपने सब्जेक्ट्स लिए होंगे, so that will be your PCB, physics, chemistry and bio. So P is your pulsatile proptosis. Pulsatile proptosis will be there. So at your level, whenever you are listening to a case of pulsatile proptosis, please always think about keratoconus fistula. Then we have C. C for chemosis. Chemosis is the edema of the conjunctiva. Please don't think it to be congestion. This is not a congestion. This is actually edema of the pulsatile proptosis, because the high pressure blood from a high pressure area is coming to a low pressure area. This is your pulsatile proptosis. Then you have the chemosis. Chemosis is the edema of the conjunctiva. And then we have brew. Brew is the noise in the head. You have the noisiness in the head. This is your bandage triad. So at your level, if they are giving you a history of what you call as trauma, and they are giving you this triad that you have pulsatile proptosis, you have chemosis, you have got the noisiness in the head, then you are sure that this is a case of keratoconus fistula. While the nerve involvement will be same, you will have same 6th nerve involvement, you will have 3rd nerve involvement, 4th nerve involvement, as well as the 5th nerve involvement. So I hope this differentiation is very clear, guys. Yes. Now, what if it is a case of superior orbital fissure syndrome or orbital apex syndrome? This is your superior orbital fissure syndrome, or it can be a case of orbital apex syndrome. Okay, now what is happening? See, when it is just superior orbital fissure syndrome, it is only the components of this superior orbital fissure which can be involved. Now, can you tell me what are the components of superior orbital fissure? This is actually divided into 3 parts. Superior orbital fissure can be divided into 3 parts. We have a superior part, then we have a middle part, and we also have a inferior part. Now your question number 3 is, what is the structure which is dividing the superior orbital fissure into 3 parts? Can you name that structure, guys? This is your question number 3. What is that structure which is dividing the superior orbital fissure? So we are also solving the related anatomy, pathology, pharma, all the questions, microbiology also. What are the related things they can ask you? What is the structure that is dividing the superior orbital fissure into 3 parts? You have to name this. Meanwhile, we will also discuss, okay, pura full name ready, full name. So what are the parts of passing through the superior orbital fissure? In the superior part. So superior part में you have superior ophthalmic vein. Inferior में you will have inferior ophthalmic vein. ठीक है, easy है. Now along with this you have LFT, lacrimal function test, है ना, या liver function test. So L is your lacrimal. Then you have F for frontal, and then you have T for trochlear. You have lacrimal, then you have frontal, and then you have trochlear. These are the nerves which are passing. And middle. Now whatever is left, you have got fifth here. Then you have the fourth here. So which is left? This is 1 and 2. So what is left is nasociliary, that is passing here. Then you have got the sixth nerve which is passing from here, and you also have third nerve. So third nerve ke both the divisions, superior as well as the inferior. Superior as well as inferior divisions. And then you have the inferior ophthalmic vein. So see, very easily you can learn. And yes, you people have given me the right answer. Let me see who all have given the right answer. Yes, Anushka, Avinash, Reddy also, all of you have given the right answer. It is actually divided by the annulus of Zinn. So actually when it is the superior orbital fissure syndrome, it is these structures which are actually involved and not the optic nerve. Cavernous sinus thrombosis may be also not the optic nerve. Keratico-cavernous fistula may be not the optic nerve, because optic nerve passes above the cavernous sinus. Now what are the four parts of optic nerve? Let's talk about that. If I talk about the optic nerve, these are all the related questions. So you know that the total length of the optic nerve is actually 4 to 5 centimeter. ठीक है, or you can say it is 47 to 50 mm. It is something like this, and it can be divided into 4 parts. So we have got the first, second, third and fourth. First is your intraocular part. Intraocular part is just 1 mm. Then we have intraorbital. Intraorbital is 30 mm, right? So another important question, this will be the shortest part of the optic nerve, and intraorbital, this will be the longest part of the optic nerve. Another important question. Then we have intracanalicular, and you people have already told me which canal it is passing through. So it is actually passing through the optic canal. And then we have intracranial part. This intracranial part is passing above the cavernous sinus. Above the cavernous sinus. Now this is very, very important because it is passing above the cavernous sinus. That is why it is not being affected in the cavernous sinus thrombosis or keratico-cavernous fistula or the superior orbital fissure syndrome, because it is passing above the cavernous sinus, right? Now what about the orbital apex syndrome? If I talk about the orbital apex syndrome, now at the apex of the orbit you have got two things. One is your optic canal, and second is your superior orbital fissure. So this you have already done. That means if I have a case of orbital apex syndrome, it will involve the optic canal along with the superior orbital fissure syndrome. Optic canal contains the optic nerve, and that is why these patients will have diminution of vision. So can you see, if I have the syndromes around the orbit, I can have the orbital cellulitis, cavernous sinus thrombosis, Preseptal, septal, I can have fistulas, I can have superior orbital fissure syndrome and orbital apex syndrome also. Then one more thing that I have here is your Tolosa Hunt syndrome. So this time we have discussed the proptosis in children. Next time we will also discuss the proptosis in adults. I think that will again be a very important and elaborate topic. I would try to discuss that next time. Now, one more thing is your Tolosa Hunt syndrome. This is actually the chronic granulomatous inflammation. It is the chronic granulomatous inflammation which is occurring of the cavernous sinus, or it can be superior orbital fissure, or it can be the apex of the orbit. This is your Tolosa Hunt syndrome. Now, guys, anybody having any of the doubt, please tell me. Any doubt related to today's session? We have discussed all kind of the things and the syndromes that can occur in a child related to the proptosis, along with the ophthalmoplegias. What will be the differentiation, where you will get the diminution of vision, and where ऑप्टिक नर्व के लेंस एक बार ओके ऑप्टिक नर्व के लेंस ये रहे intraocular is 1 mm, that is shortest. Intraorbital is 30 mm, that is longest. Intracanalicular is about 6 to 9 mm and intracranial is 10 mm. The total length is 47 to 50 mm. Which layer of the retina continues to form the optic nerve? Which layer of the retina continues to form the optic nerve? Anybody? So what I am asking is, which layer of the retina continues to form the optic nerve? And you are also free to ask any query, any question related to the things that we have discussed today. Then somebody was asking me one question, that what is the difference between the conjunctival congestion and the circumcorneal या फिर circumciliary congestion, right? So many times we have this two kind of congestions. One is your conjunctival congestion and one is your the circumcorneal congestion. Suppose these are the eyes. This is your cornea, this is the pupil, cornea and the pupil here. Now conjunctival congestion will be actually towards the fornices and it will be arborizing pattern. Superficial vessels are free like arborizing pattern. While in the circumcorneal congestion, this is deeper congestion. So this is more around the cornea, because deep ciliary vessels are involved here, and this is going slowly towards the fornices. So basically this is in the limbal area and fornices are clear here. You can see the clear fornices here in the circumcorneal congestion. In the conjunctival congestion you will have the clear limbus. Limbus area will be clear here. So that is the basic difference between the conjunctival congestion and the circumcorneal congestion. Mnemonics of the day. Today I have told you two important mnemonics. One is the POSIC, that was the Chandler's classification, and second was the SITE, that was the risk factors. So do you want me to revise those mnemonic? वो वाला revise करते हैं. And yes, it is the nerve fiber layer of the retina that continues to form the optic nerve. Then please you can note these two mnemonics here. See, this is the risk factors of the orbital cellulitis. Please note this. This is your site. S for sinusitis, I for insect bite. Then you have got G for gland involvement. Pranav, it is not the ganglionic cell layer. It is the nerve fiber layer. Then H for hematogenous spread and T for trauma. This is the risk factors for the cellulitis, and your mnemonic is site. And then another is your this one, the Chandler's classification. C posic, P for preseptal, O for orbital cellulitis, S for subperiosteal abscess, I for intraorbital abscess, and C for cavernous sinus thrombosis. So 2 mnemonics and the discussion for the day. I hope you have understood all the syndromes. Yes, you can also look at the mantras that I have posted. That also contains the mnemonics, and every day we will be posting these mantras. Alright. So I think you must have got the case. You must have enjoyed the session. Please write it in the comment section. How did you like? And also give your feedback about the other cases that you want me to discuss in the upcoming week, so that we can discuss a case, and along with that I will give you the related mnemonics and mantras, so that you are able to learn those things very easily. So take care guys, and see you tomorrow again with the previous year questions of ophthalmology. Please do join at the right time. Take care, goodbye, and happy ophthalmology.